Hello everyone, welcome to our Zoom meeting. So today we'll have different topics. When we are ready, we can start, guys. Thank you so much.
Hello everyone. Today we have 4 different topics. We will talk first about rheumatology with Dr. Amal and her colleague. We will also talk about how to create interactive clinical case studies that will be presented to us by Dr. Ayah. And also the technology in medicine, blood detection capsule. I will present this topic. Those are our 4 topic for today. And also we have how to edit and format academic manuscript for submission. First, we can start with Dr. Amal, if you are ready. Do you hear me? Dr. Amal and Dr.
Yes,
Ruwa.
Hi, good
Okay.
morning. Good. Hi, everyone.
Hello.
Yes, just
Okay.
give me 1 minute to share
Okay.
PowerPoint, okay? Hello. Good evening, everyone. Hello?
Yes, we can hear you.
Okay.
Yes.
Hi. Okay, I'm starting to share my screen. Now it's appear?
Yeah, we can see it.
Okay. So, good evening, everyone. My name is Dr. Amal Abdullah. I'm Senior House Officer working in Cancer Center here in Muscat. So thank you all, and thank you, Dr. Nader, for this opportunity. So today, me and my colleagues, Dr. Rawa, we will start to present rheumatology, overview of rheumatology.
Dr. Amal, if you can just,
Yes.
if you can move the phone from upside to sideways.
Okay, sure.
Thank you.
Thank you. So today our topic is about rheumatology. We'll start in our objective. Our rheumatology chapter is to be able to describe how the clinical presentation of rheumatological disease can vary, components of a thorough physical examination for investigation rheumatoid complaints, how to differentiate between different rheumatological disease, and evidence-based management of rheumatological disease. So we will discuss our topics, and we will cover osteoarthritis, rheumatoid arthritis, gout, calcium pyrophosphate deposition disease, polymyalgia rheumatica, giant cell arthritis, systemic SLA lupus erythematosus, Sjögren's syndrome, polymyositis, and dermatomyositis, in addition to fibromyalgia. So let's start in osteoarthritis. So quick overview about osteoarthritis. It is the principal cause of knee, hip, and back pain in older adults, and most common source of chronic pain is mostly osteoarthritis. But we must put in our mind that avoid the reflexive conclusion that all joint pain in older adults is the result of osteoarthritis. Also, osteoarthritis can develop in any joint that has suffered injury before or other disease before. So the hallmark of osteoarthritis disease is cartilage degeneration, but not purely a degenerative disease. Subchondral bone abnormalities and focal synovial inflammation are also seen in pathological specimen. So how we start diagnosis with osteoarthritis? So first of all, we must put in our mind differential diagnosis that be inflammatory and crystal arthritis, septic arthritis, bone pain due to malignancy. Every one of these diseases have a specific feature. Bone enlargement and crepitus suggest also osteoarthritis on examination. So after detailed history and examination, we will also find in our examination in the fingers, bone in the distal interphalangeal joint mainly, and this is pathognomic. It's called Hiberden node, and in the proximal interphalangeal joint also Bouchard nodes. Osteophytes are the radiographic count of this enlargement, and asymmetric joint is in osteoarthritis. Also, joint tenderness, but true synovitis, an alternative or concomitant hysteresis. So, one that the differential diagnosis of osteoarthritis is varied. Advanced imaging like MRI study are generally not indicated. We can, by detailed history, good examination, and by X-ray, we can reach the diagnosis of osteoarthritis. So this is example of radiological finding in osteoarthritis. In the left image, we can see that there is decrease or less of joint space in the knee. And here also in the right hand, in the right photo, that we can also saw there is hip, what is called node. It's called Hiberden node. We can see it here, if it is obvious. Okay. This is about osteoarthritis, history, examination, diagnosis, and investigation. After that, we will move to management. So NICE updated its guideline on the management of osteoarthritis in 2022. First of all, lifestyle modification. All patients should be offered help with weight loss, given advice about local muscle strengthening exercise and general aerobic fitness. Second, this we can use thermal agent for hand, knee, or hip osteoarthritis. As we said previously, physical activity, assistive device like jar or bottle openers, walking aids, braces, and soles. Secondly, we can use first non-pharmacological, pharmacological, and then surgery or intervention. There is also, we still in non-pharmacological, CDC and Arthritis Foundation recommendation to improve pain and functioning in patients with osteoarthritis to like minimum of 150 minutes, 2.5 hours of moderate intensity aerobic exercise per week, along with 2 days of muscle strengthening exercise per week. These guidelines don't apply specifically to older adults. A multimodal interdisciplinary approach, including referral to physical and occupational therapy, is a key in management of chronic pain-related osteoarthritis. Now, let's move to a pharmacological agent that we use in osteoarthritis. First of all, we can use topical non-steroidal anti-inflammatory drug are first-line analgesia. May be particularly beneficial for patients with osteoarthritis of the knee or hand. Second-line treatment is oral non-steroidal anti-inflammatory drug, and we must to know that we must to give the patient BPI proton pump inhibitor should be co-prescribed with non-steroidal anti-inflammatory drug. So we give topical therapy, oral therapy, but NICE also recommend we don't offer paracetamol or weak opioids unless they are only used infrequently for short-term pain relief. And all other pharmacological treatment are contraindicated, not tolerated, or ineffective. Glucosamine and strong opioid are not recommended also. This is before glucosamine and chondroitin sulfate. This is before, but now not recommended. This is recently. Duloxetine may be tried as an adjuvant adjunct for chronic pain associated with osteoarthritis. Non-pharmacological treatment options include, as we said previously, after lifestyle modification, walking aids for knee and hip osteoarthritis. Now we can do like interventional management of osteoarthritis, for example, intraarticular joint injection for osteoarthritis, and maybe try if standard pharmacological treatment is ineffective. Patients should be aware that they only provide short-term relief, like for 2 to 10 weeks maximum. And if conservative methods fail, then refer to consideration of surgery. The last option is surgery, and we can consider for patients who have advanced refractory osteoarthritis, have clearly impaired function and reduced quality of life, and are motivated about post-surgical rehabilitation. Arthroscopic debridement for knee osteoarthritis is usually reserved for patients who report mechanical symptoms. For example, locking, give way, and weakness. Give way is physical sign initially resist force, but then suddenly collapse, closing all strengths. So this is the last option is surgery, and effectiveness has not been proved. Initial treatment with physical therapy has similar outcome. Total joint arthroplasty can be considered in patients with more extensive disabling knee or hip osteoarthritis. This is about osteoarthritis. Now we will move to another topic and common topic, rheumatoid arthritis. And what view? Rheumatoid arthritis is an inflammatory arthritis risk with system cardiovascular disease and premature death. Also affects lung and cause lung disease. Most older adults with late onset rheumatoid arthritis present similarly to younger adults. So the presentation is not related to the age. We have two presentations are unique to all the syndrome of RS3BA syndrome, which is syndrome of Hamilton seronegative symmetrical anaphylaxis with beating edema, and it is rare clinical entity that easily missed due to lack of knowledge, and it was considered as rheumatoid arthritis. But it joining as so
Dr. Amal? I think maybe Dr. Amal has some problem.
I'll just contact her. Give me a minute.
Okay.
sorry, good evening.
Yeah. Good evening, Doctor.
Sorry for that interruption. Just I will share again. Just give me 1 minute. Hello?
Yes,
Hello?
we can hear you now.
Okay. Sorry for the interruption. So now I will proceed with rheumatoid arthritis. So as we know, there is also there's two presentations are unique to older adults. We talk about RS3BE syndrome, which is remitting seronegative symmetrical synovitis with beating edema, accounts for 10% of late onset cases. Also, we have the second one, acute onset seronegative inflammatory arthritis of Rheumatology or rheumatica accounts for 25% of late onset cases. So the diagnosis of rheumatoid arthritis compared with younger adults, older adults more frequently present with constitutional symptoms like malaise, fever, fatigue, weight loss, in addition to the characteristic synovitis of rheumatoid arthritis. Older adults also with rheumatoid arthritis more likely to have a higher initial ES. Hello? Can you hear me, guys?
Yes, we can hear you.
I lost it again?
Yes.
Hello?
Yes, we can
Yeah.
hear you, Amal.
Yeah, okay. تمام. Because I cannot hear, I need. So older adults with rheumatoid arthritis also more likely to have a higher ESR, which is not specific. Check autoantibody, including rheumatoid factors. And as we know, rheumatoid factor, it is circulating antibody, usually IgM, that react with FC portion of the patient on IgG, and it's recommended for any patient who have symptoms and sign of rheumatoid arthritis. So check antibody, including rheumatoid factor and anti-CCP antibody. Radiographic evaluation can be helpful, and it must be done with all patients with suspected rheumatoid arthritis as baseline. Assessment of disease activity. We must start with a detailed history examination, and after that to do scan. From patient perspective, patient may complain of pain. We need to know pain intensity and the location of pain, duration of morning stiffness, less than 30 minutes or more than 30 minutes, severity of fatigue, functional status, if it affects his daily activity of life or not. Most common patient, if they at the end they came to the doctors, that means it affects their activity of life. In the physical examination, we must note number of tender and swollen joints, evaluation for extra-articular manifestation, including rheumatoid nodule and other cutaneous manifestation, interstitial lung disease also, pleuro, pericardial disease, vasculitis, ocular, and neuropathy disease. After that, we will do investigation and lab monitoring. We'll start with acute inflammatory phase like ESR, C-reactive protein, CBC, metabolic panel, liver function test, especially if the patient is on disease-modifying anti-rheumatic drugs. Radiograph to assess for progression of the disease, as basically we must do X-ray for as initial investigation for every patient with rheumatoid arthritis. After that, we will move to management of seropositive rheumatoid arthritis. We'll start treating as soon as the diagnosis is made, with the goal of achieving remission or the lowest level of disease activity possible. Initial approach to treatment should include initiation of one or more oral DMARDs, depending on disease severity and comorbidity, plus or minus corticosteroids. In general, patients should optimize on triple therapy with oral DMARDs before moving on the biological treatment, but to put on our mind, there is risk of reactivation of TB on biological treatment. So usually we use prednisone 10 to 20 milligram per day, may be used as the primary treatment for seronegative BMR disease and the RS3PE syndrome. In contrast to classical BMR, late onset rheumatoid arthritis may not respond promptly to low dose prednisone. So be careful even after initiation of therapy to follow up the response of therapy to the disease. In general, avoid chronic use of prednisone because it is associated with increased risk of infectious complication, fluid retention, and osteoporosis, in addition to diabetic, hypertensive, the known complication of or side effect of prednisone. Now, my colleague will proceed with the remaining of topics. Dr. Ruwa.
Hello, everyone. I hope everybody is doing well. It's my pleasure to be presenting today, and I hope you find it quick, nice, and useful. So I'm going to start with gout and pseudo-gout. So we're going to have a quick overview of gout. So what is gout? Gout is crystal-induced neuropathy. This means that there is a crystal that is deposited within the joint, around the joint or within the joint. It's more common in older adults than in younger adults. Gout has got an association with cardiovascular disease and metabolic syndrome. In regards to the cardiovascular disease, I couldn't find a solid evidence of why are they associated, but the thesis is that chronic inflammation is triggered within the whole body, not just the joints. It eventually leads to affection of the heart, and also that in the cardiovascular diseases there's use of diuretics, and so diuretics precipitate gout as they increase the amount of uric acid within the body. The incidence of postmenopausal women approaches that in men. Again, I couldn't find any solid evidence of why is this the case, but it is thought that the increase in weight in postmenopausal women might be related. Other risk factors is use of diuretics, niacin, polypharmacy, renal or hepatic impairment. So the clinical presentation of gout, it could present in either subacute manner or an acute manner. So in the subacute manner, it is a smoldering oligoarthritis affecting the larger joints, whereas in the acute presentation, it's a monoarticular joint that is usually affected. It is an incapacitating attack. It's usually a very, very severe attack. The precipitants are usually trauma, acute non-articular illnesses requiring hospitalization, which brings us back that gout is very related to inflammation. Abrupt change in uric acid concentration, for example, due to dehydration, particularly after surgeries when patients are MBOs or after admissions for congestive cardiac diseases, where aggressive diuresis is used to relieve the symptoms and the congestion. As mentioned earlier, it is characterized by an abrupt onset of intense inflammation and pain, typically reaching the maximum intensity of pain within 12 to 24 hours. The resolution usually is within 7 to 10 days, even without treatment. So the diagnosis of gout requires at least one episode of swelling, pain, or tenderness in a peripheral joint or perissa with the demonstration of monosodium urate crystals from the synovial fluid or an aspirate of tophus. Tophus, which is, they are large uric acid crystals. You can see them here. This is a tophus. It's a large uric acid crystal.
Dr. Ruwa, excuse me.
Yes.
Can you also flip your phone to the sideways so the screen will
Okay.
be full size? Thank you.
That's okay. Um, so this is
Actually, the phone itself, can you make it sideways in your hand?
yes. So in your yes, I flipped the phone. So if that's you're aiming for.
That's okay if it's not doing that. Thank you. Go ahead. You can continue.
So this is the image of a tophus, and uh, with the radiographic wise, you may see juxta-articular erosion of the involved joints. So it's called the Martel sign, and it helps differentiate the arthritis from the rheumatoid arthritis. Um, Here you can see there is a prominence, a bony prominence. So this Martel
Hello, Dr. Roa. I think you have some problem in your voice. Can you hear me?
I apologize for the technical defect.
No,
Just
it's
give me a minute.
okay.
So, when it comes to gout management, we should advise the patient about modifying their lifestyle. We should lose weight, and I'm very sorry. We should advise the patient to lose weight and avoid rich foods such as shellfish, mollusk, organ meat, and full-fat dairy products. Avoidance of alcohol, particularly beer, which is especially purine rich, and reinforcing the importance of lifestyle modification at each follow-up visit. These changes can be difficult to implement and sustain, and can be invaluable, but it can be invaluable in preventing future attacks. Okay, so the management of acute attacks, first of all, we should, relieve the pain of the patient, topical therapy with ice, short-acting nonsteroidals if tolerated. There is, no peptic ulcers, no GI upset or so. For monoarticular attacks, intra-articular glucocorticoids, assuming that septic joint arthritis has been excluded, and for polyarticular attacks or glucocorticoids tapered over 5 to 10 days should be used. Glucocorticoids could be preferred to non-steroidals for treating gouts in older adults with multiple comorbidities. Low-dose colchicine is also an option, but the use is often limited by the presence of renal impairments. As for the long-term management, you albuterol, for patients here,
Dr. Rawa, Dr. Rawa, maybe I can share my screen, and I think there is a technical issue, so I will share the screen and then you can tell me when to move to the next screen. Maybe that will help the sound because it's in and out. You can go ahead.
Just 1 minute, I will call her. Maybe there's
I
connection
am
problem.
here present.
Okay.
Go ahead.
I can continue, Dr. Nader?
Yes, go ahead. Is this the right slide?
Yes, this is right. Correct. So
Go
consider
ahead.
uric acid lowering therapy such as allopurinol, febuxostat, or propanicid for patients with more than 2 attacks in a year. Some references say 1 attack is enough. Evidence of tophi or erosive disease or chronic kidney disease stage 2 or higher. Our goal is to lower the uric acid to 5 to 6 milligram per deciliter. We should indicate the patient that this may precipitate a flare. As uric acid lowering therapy is titrated up, it's reasonable to use a prophylactic agent such as colchicine at dosage as low as 0.6 milligram per deciliter. That is renal functioning. That is if the renal function is permitted, or low dose prednisone for several months. If the patient develops acute gout attacks while on uric acid lowering agent, he or she should continue the medication daily while adding an abortive treatment. Slide, please. So now we move on to the CPDD, the pseudo-gout, calcium pyrophosphate deposition disease. It is like gout, it's a crystal-induced arthropathy. The calcium pyrophosphate crystals go on to deposit within the joint space. It is more common in older adults than the younger adults. It can mimic rheumatoid arthritis, inflammatory osteoarthritis, gout, or septic arthritis. It is associated with disorders of calcium metabolism, for example, hypomagnesemia, hypophosphatemia, and hyperparathyroidism, anything that disorders the metabolism of calcium, hypothyroidism, and hemochromatosis. Okay, it can result in acute and intermittently inflammatory arthritis of the knee, hip, wrist, and metacarpophalangeal joints. Elbow, shoulders, and or ankle involvement are less common. It can mimic an acute attack of gout. It has the same sudden onset of pain, swelling that coincides with or immediately follows an acute illness or traumatic event, such as surgery, same as gout. So the diagnosis is through erythrocentesis synthesis with crystal analysis, and it's useful to distinguish CPPD from gout and infection. When there is fever, we should distinguish CPPD from septic arthritis, and the diagnostic erythrocentesis is indicated. CPPD is commonly suspected by radiographic findings of chondrocalcinosis on the plain films, which is this appears as a stippled or linear calcification of the articular cartilage of the knee, wrist, hip, shoulder, and symphysis pubis. Whatever was the affected joint, you will see that there is a line of heavy whiteness that is not present normally in normal joints, as you can see here. The management of CPDD is intra-articular steroid injection. This can result in significant relief of painful symptoms and may be preferred option if only one joint is involved. Short-acting non-steroidals and oral steroidal agents are useful in patients who can tolerate them. Evidence for the use of colchicine is limited. Oral colchicine for acute flares is typically dosed 0.6 milligram Q8 per 24 hours, similar to acute gout treatment. Colchicine can also be useful to prevent future attacks. Okay, so we move on to the polymyalgia rheumatica. So polymyalgia rheumatica is an inflammatory rheumatic disease that occurs almost exclusively in patients above 50 years of age. And this is very important because our main differential diagnosis is rheumatoid arthritis. The age helps us to differentiate between rheumatoid arthritis and polymyalgia rheumatica. So it presents with persistent pain, stiffness of bilateral upper limbs, shoulders, hips, or thighs. It may start as a unilateral affection of the joint, but eventually it will affect the other joint on the other side. So it might be starting with one shoulder getting affected, but as the disease progresses, the other shoulder will be affected as well. Hips or thighs, accompanied by significant morning stiffness that could last for about 45 minutes up to 1 hour, and constitutional symptoms such as fatigue, low-grade fever, anorexia, and weight loss, which we may find them in almost every rheumatological illness. So approximately 50 to 20% of patients with polymyalgia rheumatica also have giant cell arthritis. And we should keep this in mind because if we diagnose or suspect a patient is suffering from polymyalgia rheumatica, we should actually look for giant cell arthritis and vice versa. Slide, please. So, the European League Against Rheumatological Diseases and the American College of Rheumatology have issued a criteria in order to make the diagnosis of polymyalgia rheumatica easier. We have got three main criteria that the patient should meet. He should be aged above 50 years, bilateral shoulder pain or aching that is not explained by another etiology, and increased ESR or CRP. So interestingly enough, ESR helps us CRP is more sensitive to the presence of polymyalgia rheumatica, but ESR helps us to predict if the disease will relapse or no. The higher the ESR, the more likely the patient is going to have a relapse in the future. If all these three criteria are met, the diagnosis of PMR is suggested based on a scoring system that includes morning stiffness that lasts more than 45 minutes, negative rheumatoid factors and/or anti-CCB antibodies, which helps us to differentiate polymyalgia rheumatica from our main differential diagnosis, rheumatoid arthritis, pain or limited range of motions of the hip, or absence of other joint involvements. Another modality to aid in our diagnosis are the ultrasound findings. We can find unilateral or bilateral subdeltoid bursitis, which is inflammation of the bursa around the shoulder joints, biceps tenosynovitis, glenohumeral synovitis, hip synovitis, or trochanteric bursitis. This increases the specificity of the criteria. Slide, please. So the diagnosis of polymyalgia rheumatica, as mentioned earlier, unlike rheumatoid arthritis, there is no evidence of inflammatory arthritis of the small hand joints, although this might happen, but it's unusual. Unlike in inflammatory myopathies, normal muscle bulk and strength. So in the inflammatory myopathies, we will expect the weakness of the muscles, okay? And as a result, the enzymes of the muscles are higher. You'll not find this in polymyalgia rheumatica, so the lack of the hand joints involvement differentiates polymyalgia rheumatica from rheumatoid arthritis, and the normal muscle bulk and strength differentiate polymyalgia rheumatica from inflammatory myopathies. So typical findings are increased ESR or CRP, as mentioned earlier. ESR predicts the relapse, and CRP is more sensitive to the presence of the illness, negative rheumatoid factor, anti-CCB antibodies, and anti-nuclear antibodies, a normal level of muscle enzymes, unlike in the inflammatory myopathies. So the plain radiography of the involved joints should not reveal abnormalities, and the arthritis of the PMR is not elusive, so the plain radiographs are clear. Slide, please. So the management, the symptoms of PMR should respond dramatically and quickly within 2 weeks to prednisone, about 12.5 to 25 milligram. So this also helps to differentiate the polymyalgia rheumatica from rheumatoid arthritis. You will not find this type of response in rheumatoid arthritis. So the duration of treatment required varies from 12 to 18 months. The tapering down of the steroids should be gradual. And while you're tapering down the steroids, you should be monitoring the patients for the relapse of the symptoms. You can consider methotrexate as a steroid-sparing agent for patients with high risk complications and those unable to taper the dose effectively. Next slide. So now we move on to giant cell arthritis. As mentioned earlier, it is closely related and ambiguously related to polymyalgia rheumatica. Giant cell arthritis is also called temporal arthritis. It's a granulomatous vasculitis that involves large and medium-sized vessels. So like polymyalgia rheumatica, the disease is unique to older adults and usually affects women more, just like polymyalgia rheumatica, and it occurs almost exclusively in patients above 50 years of age, and this is the age where patients also are affected by polymyalgia rheumatica, and the incidence increases with age. Okay, so any patient. Okay, so the clinical findings of giant cell arthritis. The best known manifestations are cranial arthritis that may result in loss of vision. Patients usually present with headache, either it's a new headache or if the patient has got history of headache, he is going to complain of a new type of headache. The headache is usually dull, usually affecting the temporal side and the occipital side of the scalp. And other symptoms may be found that implies cranial arthritis, like jaw claudications. But the giant cell arthritis may present initially with extracranial arthritis, systemic inflammatory symptoms, PMR, or any combination. The head and neck manifestations are headache, scalp tenderness, jaw, tongue claudications, diplopia, prominent tender. Okay, there will be usually tenderness to the temporal side, erythematous or nodular temporal arthritis, which are typically pulses. So the constitutional symptoms include fatigue, malaise, weight loss, and fever are common and maybe the only manifestation, like most of the rheumatological illnesses. Okay. So the clinical presentation: optic nerve pallor or swelling portends ischemia with impending blindness that warrants immediate corticosteroid. This is our most dreaded complication of giant cell arthritis, is the permanent loss of vision, which unfortunately, if it happens in one eye, if not managed quickly and effectively, can affect the other eye as well. So the giant cell arthritis can present as sudden blindness with any prior systemic illnesses. Giant cell arthritis may present with claudications in the arms, respiratory system, TIA, stroke, peripheral neuropathy, syncope, ischemic necrosis of the tongue or the scalp, although very rare, and also rarely MI. So this is a reminder that this disease affects medium and large size vessels. A late manifestation of the illness is aortic aneurysm. Okay, slide please. So the diagnosis, lab findings include increased ESR or and CRP, possible anemia of chronic disease, thrombocytopenia, leukocytosis, hypoalbuminemia, and ALB. Serological tests are generally not helpful. So temporal artery biopsy is the only test that is able to definitely diagnose giant cell arthritis. Because of the focal segmental nature of giant cell arthritis, inflammation may be missed initially. There will be areas affected by the inflammation past the granuloma, areas that doesn't have the granuloma. While taking the biopsy, you just simply don't know which area are you targeting. So a section of asymptomatic site can be obtained if the initial specimen are negative. Slide. So the management with a positive biopsy or convincing history and symptoms, start oral prednisolone 40 to 60 milligram per day to reduce the risk of sudden blindness. So, and you don't even have to wait for the result of the biopsy or anything. If you suspect temporal arthritis, treat the patient immediately. IV glucocorticoid for patient with transient or permanent vision loss, diplopia, TIA, or stroke. Maintain the dose for at least 1 month. Treatment typically continues for 1 to 3 years, and concomitant low dose of aspirin decrease the risk of vision loss and cranial ischemia complication. Relapse is common after steroid is withdrawn. Monitor the patient for the return of the symptoms of gland cell arthritis or polymyalgia rheumatica as they're closely related. Monitor for the increase of the inflammatory markers. Slide. So, finally, we have SLE, systemic lupus erythematosus. It's an autoimmune multisystem disease, most commonly affects women of childbearing age. In fact, 90% of SLE patients are women, and among those women, they are mostly of childbearing age. So compared with SLE in younger adults, the late onset SLE shows less of a female predominance, is less commonly characterized by malarash, photosensitivity, arthritis, which are the typical features of a patient presenting or a young lady presenting with SLE, and nephritis and other familiar features of SLE. Typically fulfills fewer ACR criteria for the classification of SLE and is more commonly characterized by pulmonary involvement and sinusitis. Slide. So diagnosis of SLE. We use the 1997 ACR criteria for the classification of SLE. We evaluate for the rash, oral or nasal ulcers, non-erosive arthritis, evidence of piercitis, cognitive or neurological disorder, history of Zika, symptoms that are not medication-induced, and history of rhinoid phenomena. The initial lab investigations are CBC to evaluate for cytopenias, metabolic panel, and urine analysis, serologic testing for ANA, and anti-double-stranded DNA and antibodies. So as mentioned earlier, the typical features is women of a childbearing age with rash, fever, and joint pain. You should directly evaluate for SLE. As for the late onset lupus, anti-ribonucleoprotein or anti-TMS antibodies are less likely, but patients are more frequently positive for rheumatoid factor, ANA, anti-Rho Sjogren syndrome antibodies, and anti-La SSB. Slide. So there is another trick in diagnosing SLE is distinguishing the drug-induced SLE from the late onset lupus. The most famous drug-causing drug-induced SLE is hydralazine. So it is quite difficult to distinguish late onset lupus from drug-induced SLE. It is often clinically difficult. Both has positive ANA test. All the drug-induced lupus is associated with a SPECT pattern with antihistamine antibodies. You'll find antihistamine antibodies with the drug-induced lupus, but still it is difficult to distinguish. For renal biopsies, patients who have proteinuria or active urine sediment to determine the histopathology pattern before starting the treatment. So one of the initial investigations definitely is urine analysis to look for protein, serological evaluation for antiphospholipid syndrome for patients with evidence of thromboembolic diseases, as antiphospholipid syndrome can occur frequently in SLE patients. So the management of SLE, as for older adults, no clinical trials involving them has been done, unfortunately, but our initial treatment is short-acting nonsteroidals if tolerated in order to treat the arthritis and sinusitis. The anti-malaria hydroxychloroquine is pivotal in management of SLE. It is effective in managing skin and joint manifestations. Macular degeneration is a contraindication. In fact, macular degeneration is a contraindication for using hydroxychloroquine, and it is a side effect of using hydroxychloroquine. So you should always monitor your patient for the visual effects. You should always check that their retina is all right. Consider low-dose corticosteroid for patients with symptom refractory to hydroxychloroquine. Most significant side effects with long-term steroid use may overweight the potential benefits. As we know, steroids are magic, but their side effects are also slide. So depending upon the organ system involved, as mentioned earlier, SOE is a multi-organ disease. It can affect the heart, it can affect the renal system, can affect a lot of organs in the body. So depending upon the organ system involved and affected, we can use the following drugs: methotrexate, azathioprine, mycophenolate, ophthal, or cyclosporine. All are off-label, but can be beneficial if corticosteroids are not available or they are contraindicated. A patient with evidence of antiphospholipid syndrome should receive preventive anticoagulation as well as immunosuppressive therapy. They should receive, if it's a primary prevention, they should receive low doses of aspirin. For secondary prevention, anticoagulants are preferred. High doses steroid and cyclophosphamide are reserved for the severe neuropsychiatric manifestations and venal manifestations of SLE. Slide. Okay, now I'm done. I hope you enjoyed it. Very sorry for the technical difficulties, and Amal will continue the presentation.
Yeah, thank you, Dr. Ruwa. I will share my screen now. So now I will proceed with the remaining of topics. We will now talk about Sjogren disease or Sjogren syndrome. So firstly, Sjogren is from it came from Dr. Henrik Sjogren. He was a Swedish doctor that he noticed that a lot of women came to him with a dry mouth, dry mucous membrane, and a dry eye in addition to arthralgia. So this, the name of Sjogren came from Dr. Henrik in 1933. So what is Sjogren syndrome? Sjogren syndrome is an autoimmune disorder affecting exocrine gland, resulting in dry mucosal surface. So it's systemic multi-organ chronic disease characterized by lymphocytic infiltration of exocrine gland, and it divided into primary or secondary. May develop from primary or secondary to rheumatological disease, arthritis, lupus, erythrocytosis, scleroderma, or inflammatory myopathy. We must to know that the most common Sjogren syndrome is most commonly seen in female as the ratio of 9/1 of one male, and there is marked increased risk of lymphoid malignancy, 40 to 60 fold. And we know that by the presence of palpable purpura and C4 hypocomplementemia are potential predictors for development of lymphoma. After this overview, we must know about feature and clinical presentation of Sjogren syndrome. Best known manifestation is xerophthalmia and xerostomia. This is the best. And we must know that not limited to lacrimal and cerebellogram, this dryness may present with dysphagia, weight loss, vaginal dryness, sexual dysfunction. May cause extraglandular disease, including renal tubular acidosis, bladder, liver, biliary, thyroid, nervous system, and skin manifestation. We must consider Sjogren syndrome in patients with interstitial lung disease, malabsorption CNS disease that mimics multiple sclerosis, rash, and unexplained renal, liver, or thyroid disease. We must put in our mind that Sjogren disease may not come firstly like just dryness of mouth and dryness of lacrimal gland. The patient may complain more from arthralgia, from sensory arthritis, or a recurrent episode of parotitis. So it is not very clear in the diagnosis from the start. We need a detailed history, full examination, because the symptoms and the sign is vary from patient to patient. First of all, we must to put in our mind to exclude the drug-induced symptoms, particularly that anticholinergic drug and their anticholinergic side effect, age-related exocrine gland fibrosis or fatty infiltration, other connective tissue syndrome. In the investigation, we usually use Schirmer test and slit lamp examination to assess for corneal damage and confirm the presence of keratoconjunctivitis. And the investigation, we will start with a routine investigation, CBC, RFT, LFT, and so on. Then we will go to autoantibody, ANA antibody, which is not specific for Sjogren's syndrome. Rheumatoid factor positive is nearly 50% of patient. Anti-Rho antibody is 70% occur in a patient with Sjogren's syndrome. So anti-La is like 30%, and as we already say, rheumatoid factor usually positive, but it's not specific. So let's move to management of Sjogren's syndrome. So management for exerostomia, we'll start with sugar-free candies, artificial saliva, just for avoid the avoid the dryness. Counsel patients on maintaining good dental health to prevent caries, gum disease, and dental erosion. Cholinergic side effects limit the use of pilocarpine and cevimeline in older patients, but it may be useful to stimulate saliva production. For exophthalmia, lubricating ointment, artificial tears, consider punctual plugs to retain tears. For inflammatory eye disease, so be the patient keratoconjunctivitis and the treatment of ophthalmic cyclosporine. So now we will move to another topic, polymyositis and dermatomyositis. So polymyositis and inflammatory myositis and inflammatory muscle disease, including polymyositis and dermatomyositis, form a heterogeneous and uncommon group of skeletal muscle disease. Incidence peaks in adults in their 50s, but this disease can occur at any age, and up to 20% of cases are in adults more than 65 years old. The most common presentation of these patients with polymyositis and dermatomyositis are muscle weakness is the central feature of polymyositis and dermatomyositis, most prominently in the proximal muscle group, mainly. Muscle tenderness is unusual, should raise suspicion of other condition if this patient have muscle tenderness. So the patient usually came with symptoms of arthritis when present is inflammatory and occasionally erosive, suggesting overlap with rheumatoid arthritis. Esophageal dysmotility can cause dysphagia, hoarseness, and aspiration also. In addition to that, arrhythmia, symptoms of congestive heart disease, dyspnea on exertion, or persistent cough suggest cardiac muscle involvement or coexistent interstitial lung disease. Pulmonary involvement is a poor prognostic sign if occurred. Raynaud phenomena or Sjogren's syndrome can present also. Dermatomyositis is a variant of disease that occur in the skin where skin manifestation are prominent, for example, Berber rash or rash in the cheek or around in the eyelid, and it's characterized mainly by rash, and it's very like heliotrope or Guttering babule. So look the variety of all these symptoms. Some patient may come with arthritis, the other one may come with pulmonary involvement. So as we know, detailed history from the patient itself, examination and investigation as probably is must to be done. Because the presentation is varies from patient to patient, and even one patient may have a lot of symptoms that lead to more than one or more than 5 differential diagnoses. Myositis, the diagnosis of myositis, differential diagnosis, endocrine, metabolic, musculoskeletal, and medication-related disorder, including thyroid disorder, diabetes, vitamin D deficiency, electrolyte abnormality, BMR, and side effect from steroid or statins, we must put in mind. Initial evaluation, we must exclude more common causes of muscle weakness like statin use, especially if combined with macrolide erythromycin. Serum level of muscle enzyme, creatine kinase, aldolase, and sometimes transaminase are usually increased in myositis. Normal levels suggest an alternative diagnosis. So we must use also electromyography is used to exclude neuropathy and identify an irritable myopathy. MRI, it is the best, and using fast suppression sequences help to confirm myositis and can help select which muscle to biopsy. The gold standard of treatment is muscle biopsy, and to confirm the diagnosis and distinguish a subtype of myositis. Also, we can use in the diagnosis anti-synthetase antibody, anti-Jo-1 antibody are seen in pattern of disease associated with lung involvement, rheumatoid, and fever. Diagnosis of dermatomyositis and less so with polymyositis warrants heightened suspicion of an underlying malignancy. Recommend age-appropriate cancer screening. So we must put in our mind that malignancy also may occur in those patients with myositis. So now after the diagnosis, we must move to management. So management of dermatomyositis, typical initial therapy will start with oral prednisone, 1 milligram per kg per day, and try to taper the total dose by 10 to 20% per month. For severe disease, methylprednisolone, 1,000 milligram IV over 3 consecutive days. Methotrexate off-label, given orally or parenterally in a weekly regimen, can be combined with corticosteroid and can also have a steroid-sparing effect in long-term therapy. But we must put in our mind the side effect of methotrexate, so we use it if high dose of prednisolone not effective. Also, azathioprine may be used as a steroid-sparing agent. Weekly oral methotrexate or myclophenolate modifier, also off-label, may be effective in managing refractory skin manifestation of dermatomyositis. As I said already, azathioprine, we can move to intravenous immunoglobulin, can be effective in refractory dermatomyositis and is generally considered relatively safe. Also, older adults are at increased risk of renal failure and thrombotic event. So we must to put in our mind that the cons and pros of those medication. Supervised exercise has proved beneficial in polymyositis. The last topics in our rheumatology review is fibromyalgia. So what is fibromyalgia? Fibromyalgia is a syndrome characterized by widespread pain throughout the body with tender points at a specific anatomical site. The hallmark is generalized body pain. Can be associated with other complaints such as mood disturbance, fatigue, cognitive disorders, somatic symptoms, and as we said previously, woman is almost the the win in rheumatological disease. Always woman is high, it's like more like 5 times in fibromyalgia rheumatica, and all rheumatological disease, woman is number one in the rheumatological disease. So can be associated with other complaints such as mood disturbance, fatigue, cognitive disorder, somatic symptoms, may coincide with chronic pain from a variety of sources, including osteoarthritis, neuropathy, and degenerative spinal disease. Diagnosis of fibromyalgia rheumatica is made using widespread pain index and symptom severity scores. So with symptoms present for at least 3 months and no other explanation for symptoms, to be honest, is very fibromyalgia rheumatica is very difficult to diagnose it, because it's like patient came complaining of pain for a long time, and we did a lot of investigation and details history, and after examination there is no clear focus of the pain. So it's like diagnosis of exclusion. Aside from generalized soft tissue sensitivity, physical exam should be normal for age. Importantly, patient will not have evidence of inflammation or synovitis on physical examination. Lab abnormalities such as increased ESR or C-reactive protein should promote investigation for an alternative diagnosis. So, as we said, the feature is a chronic pain, cognitive impairment, which is called fibrofoot, sleep also disturbance, headache, dizziness are common. And now we will move, after diagnosis, we will move to treatment of fibromyalgia patients. We will start non-pharmacological, pharmacological, non-pharmacological physical activity, patient education, and cognitive behavioral therapy are the key to symptoms relief. When encouraging physical activity, reassure patients that increased pain on activity is probably temporary and not necessarily harmful, and increase physical activity slowly and in small increments that are easily sustainable. And also, we must address chronic pain, sleep disturbance, and depression and anxiety individually for each patient. Critical to form a therapeutic alliance between physician and patient, because the patient will always come complaining of pain. So it will be need more than one aspect. In addition to pain relief, we need psychological, cognitive behavior therapy. All of these we must to advocate on the treatment. Now let's move to pharmacological treatment. FDA approved medication pregabalin, duloxetine, and malnacipran. So acetaminophen, anticonvulsant, antidepressant, and awake opioids such as tramadol have been studied specifically for older adults with fibromyalgia. Most medication used to treat fibromyalgia provide only modest benefit despite considerable risk of a side effect. So individualized pharmacological therapy based on the specific symptoms and reassess frequently for effectiveness and advice effect. This is all about fibromyalgia. So in summary, osteoarthritis is the most common cause of chronic pain among older adults. History and physical examination remain the most important tools for diagnosing and distinguish among the rheumatological disease. When developing treatment plan for older adults with rheumatological disease, keep in mind each patient's comorbid medical condition, functional status, and potential for drug and drug disease interaction. Interventions ideally use a multimodal approach, including pharmacological and non-pharmacological treatment, as well as rehabilitation modality. So we must put in our mind that rheumatology can in your school or during your reading, it is an easy topics. But during practice, rheumatology is really need detail and need detailed history, need detailed examination, because the patient, because the symptoms of the patient varies from the beginning of the disease till the progression of the disease. So this is all about rheumatology. I hope you enjoy, and thank you very much for listening.
Thank you, Dr. Amal and Dr. Ruwa for the great presentation. If anyone have a question for them, please go ahead, or you can write it in the chat below so we can move to our next topic after that. Our next topic will be with about how to edit and format academic manuscript for submission, Manuscript Magic. It will be presented by Dr. Ayah Isam. Dr. Ayah, are you available? Can you hear me?
Hello, can you hear me?
Yes, I can hear you.
Okay.
If you are
Hello,
ready,
good evening,
share your
guys,
screen.
and thank you very much for attending today. My name is Dr. Ayah Abdullah, and I'm very pleased and happy to present for you today a topic about manuscript writing and submission. Just a sec. I need to share the screen with you. Can you see the screen now?
Yes, we can.
Okay. Okay, so today I'm going to present manuscript writing. I'm going to talk about structure, style, and best practices. Overview, we're going to talk about what is manuscript, how to prepare to write the manuscript, and the most common structures, how to write each section, and I'm going to give you some tips about the language and styles and most common mistakes. So simply, as we all know, manuscript is a written document that presents original research, analysis, or insights intended for publication in a journal. It typically follows a formal structure and aims to communicate findings clearly, accurately, and transparently to scientific community. So this is the importance of manuscript. This is why we need to make it in a systematic way so that we can communicate in the scientific and research community. There are so many types of manuscripts, most commonly research articles, reviews, and case studies. There are so many. So basically, I'm going to give you 3 examples today, but there's a lot more than these types. The first one and the most common one, and this is the one that I'm going to talk in details today, is the research article, original article. We use this type of manuscript when we want to present new or original research data. The typical structure is title followed by abstract and introduction. However, this type of manuscript focuses on methods, results, and discussion. By the end of the article, we usually give conclusions and then write your references. The key features is it follows IMR AD, and we're going to go through this type in a minute. It focuses on data, methodology, and findings. Okay, this is the original article. Another type is review article. The purpose is to summarize and analyze existing research, not to present new data. So this one focuses on thematic section. and critical discussion and synthesis. So no methods, no results, as in the usual research article. It's just summarizes and analyzes an existing research. And the last example here is a case study or case report. The purpose is to describe a unique or noteworthy clinical or research case. So the typical structure is title, abstract, and introduction, and then it focuses on the case description, the patient data, and the event. And then this is followed by discussion. These are the most important parts in the case study or case reports. So no broad methods and results sections here. Okay. So before we all start writing the manuscript, first identify your target journal. Okay. So how could you identify your target journal? It depends on the target population, or target populations that you want to publish this journal at. Then, after identifying your target journal, understand the journal guidelines, go through it carefully because it's different from one journal to another, and then plan your study and then prepare your data, visuals, and references. Okay, so for a standard manuscript structure, we followed this IMR-AD, introduction, methods, results, discussion. And then the additionals are the title, abstracts, and keywords, conclusion, and references. Okay, so this is an example here for a published manuscript. As we all see, the title is clear at the top of the page, and then there are the authors' names. The first one is the first author, the one who came up with the idea, and so on. And then the affiliation, and then the correspondence contact details. And then it's followed by the abstract here. The abstract is just like a summary to all the most important and key features of this paper. And then the keywords. We're going to go through each part of the manuscript. So the title, abstract, and keywords. The title has to be clear and concise. Abstract has to be a summary of objectives, methods, results, and conclusion. And keywords, 4 to 6 terms. Okay, so in the introduction, try to keep the introduction to define the problem, provide a background about what you're going to talk about, and then identify the knowledge gap. This is very important. This is where we're going to tell people that my manuscript or my research is important because there is a knowledge gap in that area. And then state the objectives. In the methods section, we're going to state the study design, participants, material, how was the data collected, and then how was it analyzed. In the results section, we present the data logically. We use tables and figures, avoid interpretation. Why we avoid the interpretation? Simply because we're going to do that in the discussion section. We interpret the results and compare it with literature. And then by the end of the discussion, we give the implications, limitations, and future directions. In the conclusion, try to make your conclusion short, straightforward, and direct. Emphasize contribution and link back to objectives. We conclude and then we say that this is linked back to the objectives of this research that we've done. Here we see more additional parts that some papers may ask you, some journals may ask you to provide, which is the ethical considerations, Okay. And here clearly that the ethical clearance was obtained from Department of Community Medicine, Faculty of Medicine, so on. And then author's contribution, and then disclosure, like all authors report no conflict of interest, and references. References has to be the journal's guideline, according to the journal's guidelines. Okay. This is just simple tips for general formatting using Microsoft Word, a Times New Roman, size 12, or Arial size 11, or Calibri size 11, double spaced, and standard margins. Okay. Regarding language and style tips, try to make your manuscript clear and concise using active voice. Avoid jargon, which means use scientific language as much as possible. Simple sentences and make it straightforward. Follow journal style guides. In the end, I just wanted to tell you that manuscript writing is a skill that develops with practice. So practice, 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 and then seek other expert opinion or supervisor's opinion to guide you to make it more clear and better. Common mistakes that people do during making manuscript is sometimes they make long introductions. So the introduction has to give you just an idea about the topic that we're going to talk about in this research. So just make it simple and clear. Poor figures in the results section. So just try to make it figures as clear as possible. Ignoring guidelines, and this would lead this is the most common cause of rejection for manuscripts. So please try to follow the journal, the specific journal that you want to publish at, as possible. Weak abstract. And this is a critical point. Why? Because the abstract is the first thing that the reader is gonna see about your manuscript. And you have to include all the important information and key points in your research, and avoid including extra points that are unnecessary. Okay, and supporting claims is that you cannot claim anything, especially in the discussion part, without providing an evidence from literature. So please, when you claim an information, try to provide an evidence from literature as possible. Thank you very much.
Thank you, Dr. Ayah.
Thank you so much for listening. And if you have any question, do not hesitate. Thank you.
Thank you so much, Dr. Ayah, for this clear presentation. Does anyone have any question for her? Or we can continue to our next topic, which is creating interactive clinical case studies using Google Slide or PowerPoint, which will be presented by Dr. Ayah. Are you ready, Dr. Ayah?
Yes, I'm ready.
Okay.
Can you see my screen?
Yes, it's clear.
Hello, everyone. My name is Ayah Gharaibeh. Before I start today, allow me to take this chance to thank Dr. Nader for this great opportunity. Today, I'll be sharing with you some tricks and tips to help you turn a basic presentation into a more interesting and interactive one. Okay, so how many of us here today have fallen asleep during a lecture or a presentation? If your answer was yes, you're not alone. About 30% of medical doctors have admitted to falling asleep during a lecture too. This is actually my first trick for you. Start your presentation with a question or a poll. This will get your audience engaged right away. Have you noticed in live presentations, the speaker usually moves around the stage to engage the audience? Like in TED Talks, you see them walking around. Well, since physical movement is not applicable in virtual settings, so we do the next best thing. We try to make up for it with videos, transition, and animation. Any kind of movement keeps the audience engaged and interested. So we know that what you say matters, but also how you say it. Adding in photos isn't just for visual interest. For example, if we take this slide, which is a physical examination of a patient, there's a lot of text. If we switch it into this one, we just added some photos, a simple table. This second slide is much easier to read, even though both slides contain the exact same information. Now on to the next tip is organizing into table and charts. And not only images are gonna give or make the presentation easier to read or make it speak louder, tables and charts work in the same way. So we have this slide. For many of the people viewing, they wouldn't even bother reading, and even if they did, it would take them about a minute to finish this slide. In comparison to this one, right away, just by looking at it or glancing at it, you can easily tell that smoking surpasses all other causes of preventable cancers. So you see the difference here, just using the charts made it speak much louder than just having a text. So we all agree that having a bulky slide is kind of boring and not very interesting. So breaking it down is very useful. When we break down a slide, for example, this one, even though this slide is colorful and it is visually interesting, it feels somewhat dense. Now, if we did split it up into 4 separate slides, you'll see that each degree of heart block is much easier to read. The ECG is much clearer, and you feel like each type of heart block is in its own a thing. It gives it more of importance, which is exactly my next tip. Emphasizing. Emphasizing means give information that you want to highlight or show, give them their own moment, have it in their own slide. Usually they do that with big numbers because big numbers are very eye-catching. They use this in advertisements all the time. You can do that too. You can use numbers like to show how common your disease is. Use that to demonstrate the prevalence of your disease or the disease that you're presenting. Now comes the actual interactive stuff. Annotation. Annotation means adding on to your slides in real time. And as I assume a lot of you know, this is done by just right-click on your screen, go to pointer options, and then you can choose whatever option you want. Here, I'm gonna choose highlighter for myself. And here I can add onto the slides as I go. When you finish your presentation, it will ask you if you want to save your annotations or discard them. Now, in about this time, if it was a live presentation, a presenter might ask the audience to split into smaller groups and have them work through an exercise. The virtual equivalent of that would be working through an example with your listeners. Here I chose an ECG, for example. So here we allow discussion. We want the interaction from the audience. So you'd start asking questions like, can you identify 3 ECG findings? If you feel like the audience isn't really getting engaged, you can be more specific and guide your audience. Like, for example, can somebody tell me how much the heart rate is based on this ECG? Give your audience time to respond to you before you actually show the correct answer. And during the discussion phase up here, it would be a great time to use the annotation, because right here you can show, like, you can start interacting live in front of your audience so that they feel like they are there with you. Finally, I'm gonna show you how to create a hyperlink. You can add a hyperlink onto anything. It could be a text, a shape, a button, whatever you want. And a hyperlink is basically just adding a link that will either open up, play a video, send you to a website, or move you throughout your presentation. So you select whatever item. So let's assume I want to select this text that says link. Right click, and then you go back down to link. And from there, you can choose what exact action you want that hyperlink to do. Again, like going onto a website, playing a sound, playing a video, whatever it is. Once that link is created, if you do choose a text, the text will become underlined and blue in color. Other shapes or items, the only way to tell that there's a hyperlink on that item is that when you do bring the pointer near them, the pointer turns into that shape, and that means that the hyperlink has been created. Usually, hyperlinks are used for references, additional reading material, and moving throughout the slides. A general rule that a lot of people are talking about is the 10-20-30 rule, which is have no more than 10 slides, talk only for 20 minutes, and do not use a font size larger than 30 because that's not visually attractive. Though honestly, this rule is very hard to follow when you're actually making a presentation, because 10 slides is a very, very small number. In summary, these are the main tips that could help you create a more interactive presentation. There is no exact formula for how to create it, so mix and match as you please. And remember to always be creative. These are my references, and thank you. Any questions?
Thank you, Dr. Ayah, for this presentation.
Thank you.
Does anyone have any question? Or we can move to our last topic for today, which I'll be presenting. I'll talk to you about blood detection capsule, which is a short topic. And let me just share my screen with you. Wait. Okay, can you see my screen?
Yes.
Okay, thank you. I will talk to you today about the use of blood detection capsule to guide endoscopic decision making in high-risk patient. Our content today, we will talk a little bit introduction about the capsule, blood detection capsule, their mechanism of action, their benefit in high-risk patient, and the limitation and consideration. Okay, as an introduction, a blood detection capsule like PillSense, this one in the picture here, there are many type of them, but this one here is a PillSense capsule. It's a promising tool for managing patient with suspected GI bleeding by providing a rapid, non-invasive way to detect blood in the upper GI tract. Studies show that it can influence clinical decision in a majority of cases, leading to safer and more efficient management. Specifically, it helps guide whether to perform an endoscopy, de-escalate care, or prioritize a more urgent procedure for high-risk patient. So this is the capsule that we will be talking about today, how it can help us to make this triage more rapid. So how this pill work? It is ingestible, so we give it to the patient to ingest it. It contains an optical sensor that measures light absorption to detect blood or hematine. So the patient swallow this capsule with water. Then we have a wireless receiver that is placed near the patient. It displays blood detected or not no blood detected message after a short monitoring period, typically 5 or 10 minutes. This system is designed to be rapid, safe, and easy to use with no reported adverse event. So it's like if a patient came and we suspect that he have an upper GI bleeding, um, usually we are not sure whether to give him endoscopy after starting with the ABCs, obviously. And then, if we have this capsule, it will help us to move forward with the plan, whether we need to give him like endoscopic treatment or we can defer the decision to make endoscopic treatment. Okay, let's see the benefit for high-risk patient. As we just said, it aid the triage and resource allocation because it helps differentiate between patients who may be safely discharged with close outpatient follow-up and those who require further urgent investigation. It avoids unnecessary procedure. In some cases, a negative capsule result can allow clinicians to safely avoid an endoscopy. Because if the capsule said no blood detected and we see that the patient is stable now, we don't have to do an unnecessary endoscopic procedure and we can focus on detecting the cause of his current symptom and blood test and so on. Which is particularly beneficial for high-risk patients who may have a higher risk from sedation, or they have causes that we cannot do endoscopy for them, or they have other major risk factor that we have to focus on more than doing endoscopy right now. Also, it helps us to prioritize urgent endoscopy because if we give him the capsule and the capsule said that there is blood detected, we can pause everything else and go forward with the endoscopy because it is urgent right now because we detected the blood. A positive capsule result can prompt clinician to prioritize endoscopy for patients who show signs of active bleeding. It impacts the clinical management. Many studies show that the capsule result influenced clinical management in up to 80% of cases. It helps differentiate bleeding location. It can help distinguish between upper and lower GI bleed because it tells us where the capsule detected this blood. Okay, about the limitation and consideration. The capsule primary role is to detect blood in the upper GI tract. Sometimes it does not reach far location and it definitely does not replace the need for definitive diagnosis and treatment provided by endoscopy. It just tells us that there is blood, but we cannot replace the endoscopy with this pill because the endoscopy will tell us the exact location, the amount of the bleeding, and it can be also used for treatment. While promising, further large-scale studies are needed to fully establish its real-world performance, characteristic, and comparative advantage over traditional method. There are many clinical trials about this capsule, but we still need more clinical trials and meta-analysis about it to compare it with the traditional method of triaging and whether it is better to give the endoscopy directly or to give this capsule first. Okay, so we have lots of study, but here I decided to share the result of Abu Zaid and his colleague paper with you, like as an example of one of the many studies that talked about this capsule. Their study population were 20 patients. The mean age were 64 plus or minus 16 years. 85% of their patients were male. 65% of their patients were in critical care, while 35% in high risk for sedation complication, have high risk for sedation complication. So the impact on clinical management. The capsule finding changed management in 14 out of the 20 patients that they they were included in the study, like 70%. 8 patients or 40% of those patients deferred the upper endoscopy because the capsule showed that there is no blood, and while 25% or 5 patients prioritized giving them endoscopy because the capsule detected blood. 1 patient was intubated prior to endoscopy due to capsule detection of large volume blood. They found no complication in the deferred group, the one that they did not do the endoscopy for. No later need for endoscopy, so the decision was accurate on those patients. No 30-day readmission for GI bleeding, and no death within the first 30 days. And thank you. This was my short revision for this capsule and for the paper of Abu Zaid and his colleague. If anyone have any question, or with that, we finished our topics for today. I would like to thank everyone for coming, and especially thank Dr. Nader for giving this opportunity to learn a lot from it. As always, thank you, Dr. Nader.
Thank you. Thank you, all of you. Thank you, all the presenters. These were great presentations. Now we come to the update section. Anyone wants to share their updates, please raise your hand or jump in. We have a new fellow, Dr. Muskan. Please introduce yourself. Welcome to the program, and tell us something about you.
Hello everyone. Should I open my video or is it okay?
It's okay. Whichever. We are flexible here, so go ahead.
Okay. Wait, just. I think there is one.
That's all right. Yeah.
Okay. So my name is Muskan Lohana. I'm from Pakistan. I graduated from my university in 2023 with distinction and honors. I completed all of my 3 steps, and right now I applied in March 2026. I got few interviews, and right now I'm giving some interviews. I have a little bit knowledge about the research. I have 2 publications. In which I was not the first author. I just had them doing the screening and like collecting the data. And I was a part of clinical trials where I was a part of 3 clinical trials, 3 to 4 clinical trials, which were phase 3 and phase 4 trials, where my duties were to screening the patient and doing informed consent, to perform ECG, depression screening, schedule their next appointment, and contacting various investigators. So I have this much research experience, and right now I'm here. Thank you.
Sounds good. Thank you so much. Welcome to the program. You are in Pakistan, is that correct?
Yes. Right
Okay.
now I'm
welcome.
Pakistan.
Yes. Yeah. Welcome to the program.
Thank you.
You're welcome. Anyone else? Dr. Ahmed Khalifa, any update about the seminar? Or for any one of you, any questions or any new ideas, any comments about the program or questions about today's session?
Dr. Nader, I have a
Yes.
question. One
Yes.
of my team has an idea about a meta-analysis, can we contact you about it, like send you an email, or what can we
Sure.
do?
Yeah,
Oh,
send me
thank
an
you.
email and then we can start. Yes.
Thank you, Dr. Nader.
Thank you. Any other updates or questions or comments about the program or about today's presentations? If not, I'd like to thank you all for attending this meeting. Thank you so much. And also, I'd like to thank all the presenters from today's presentations. You did great, excellent presentations. And I'd like to thank those who will come later and watch the recording. Have a wonderful day, everyone, and or night, wherever you are. See you next week, and let me know if I can be of any help. Assalamu alaikum.
Thank you, Dr. Nader. Thank you very much.
Thank you. Thank you so much. Have a wonderful day. Thank you. Bye-bye.